Hi, and welcome to Alert and Oriented Whitman Partners Speaker Series for Supporting Lifetime Learning. Today's guest is Kathy Beydler. Kathy is an RN MBA with certification in OR nursing and ambulatory surgery center management. She actually has 30 years of experience in the OR, first as an OR nurse, also as a director and administrator over hospitals and surgery centers across the country. Before I hand it off to Kathy, I just wanted to share the story about how we came to here. About 6 months ago, I called Kathy to tell her about recognized expert consulting services. She's on contract at the time, so she has to take the call. I say to Kathy, we're offering consulting services like Peri-Op 101 and survey preparedness. And she stops me and says, hold on, I wrote the book on survey preparedness. Little do I know that 3 days later, she has literally sent me her book on getting prepared for surveys. Fast forward to 6 months, and we're proud to have partnered with Kathy Beydler in printing 2021's Survey Survival Guide, the pocket guide to survey success, soon to hit C-suite bookshelves and hospital operating rooms across the country. Now to tell us a little bit about the content of the book, without further ado, is Kathy Beydler.
Thank you, Josiah, and thanks everybody for taking time to meet with us today. It is absolutely my pleasure to be here with you and to share. I'm also a former educator. I used to teach 5th grade, which, frankly has come in quite handy in working in surgery and working with surgeons, and that'll make a lot of people that work in the OR and a lot of the C-suite people smile because you know exactly what I'm talking about. So I'm an educator at heart. I'm a mentor at heart, and I am passionate about patient care and about doing things in an excellent manner. So when Josiah mentioned that they would like to publish this little book that I've had in my pocket and I've done every place that I've been, I was excited about it, and I'm very excited to share the information with you today. So Josiah, if we could go to the next slide, and then we'll see a little bit about the pocket guide and why would you want to use a pocket guide. And when I've gone into places, it's interesting because it's like I have done this pocket guide everywhere, and people are like, where did you get this information? Where is this from? And it's literally from my years of being a director, an administrator, a nurse, dealing with accreditation bodies and the surveyors as they come in, and actually being a surveyor myself. So when I give a pocket guide to somebody, the things that I hear back from them are from the leaders and from the C-suite are, and this is great because the one thing that we don't know about surgery is we don't know what's behind the red line. And, when you don't know what's behind the red line, of course, and when I say the red line, I'm talking about what's, when you have on street clothes and you can't go beyond the red line and you have to dress out, then that's what I'm talking about behind the red line. So if the leaders don't know what's behind the red line, what's actually going on, then they're vulnerable. And they're vulnerable for noncompliance, for risking not being accredited, for having deficiencies cited. And anytime you have deficiencies cited, you're going to have to correct them. So the pocket guide takes a proactive approach, which is what I like to do in leadership, is taking a proactive approach to what we know we should be doing anyway. The thing about accreditation requirements are that they change all the time. And we'll talk about that a little bit as we go forward. But that makes people a bit nervous because they don't know what it's going to be the next time. They don't know exactly what to expect. So we're looking for a way to be proactive for accreditation versus being reactive. Okay, let's go to the next one. Thank you, Josiah. And so here's what you can expect from the pocket guide. And I love the way that Whitman Partners has put this together. You'll see on the left hand of the slide, we talked about the different areas of accreditation that surveyors really focus on. So what Whitman Partners has done is they have color-coded these, and I love this because if you want to know anything about infection prevention, you go to the color that's there for infection prevention. And they've got color-coded page tabs that talk about it. And it goes all the way down to the areas of tips for talking to a surveyor, and then it also talks about recognized experts. So the information that we provide to you with this book is up to date. It will be revised every year with up-to-date standards, so you don't have to worry about, is this something that is, is it no longer required? Is it the latest information? The information that you have in your hand for that year is the up-to-date information. Again, it's a quick reference guide. It fits in your scrub pocket. When I've done these, I have given them to everybody on the team. I give them to every tech, every nurse, every support person, every leader. And the reason I don't like to just give it to leaders, the reason I don't just give it to leaders is because the surveyors are going to be asking to talk to the staff. And if they're talking to the staff, then the staff needs to know the questions that the surveyors are likely to ask. And if they know the questions that the surveyors are likely to ask, then they're going to have some of the answers. And these are not pat answers. These are answers that actually apply to the organization that's using them. And also, the thing that I like about the way that Whitman Partners has done with this book is they've made it to where you can customize it for your organization. So in different areas, you'll see throughout the book that it will have questions where you write in your answers so that your staff will be ready, so that they can just flip and say, okay, if I want to know what quality initiatives we're working on, here's where the answer is in my book. And then that's going to be listed under quality improvement. So it's an easy, quick way to find the things that you need. Okay. So here's the thing about the book and about readiness for accreditation. Things changed drastically in 2008, and the economy changed in 2008, 2009. Things changed for accreditation in 2008 and 2009 drastically as well. And the thing that happened was there was a GI center, a surgery center that was physician owned in Nevada, and they had 6 patients in Southern Nevada that developed hepatitis C. Well, 6 patients is more in a year that they would normally have. And they had 6 patients from one surgery center that developed hepatitis C. So anytime things like that happen, of course, you're going to have a laser focus on what's happened. Same thing with surveying, and we'll talk about that as well. When things happen during a survey, then the surveyor really has to dig down to see what's happening. So they had the patients with hepatitis C that were treated at the same center in Southern Nevada, and the Southern Nevada Department of Health started to look into it and to why these things were happening in a scientific manner. They started to look at it. They found out that syringes were being reused on multiple patients. They had 40,000 patients that had procedures at this center from March 2004 to January 2008. All 40,000, can you imagine? 40,000 patients were determined to be at risk for Hep C, Hep B, and HIV, and had to be tested for these diseases because they were determined to be at risk. All went back to the syringes being reused on multiple patients. So what that meant is that they would take a syringe and put it into they would take a different needle but use the same syringe. It was like this with this pen. If there's this needle on the end of this and I draw up a medication and I don't change this syringe here, I use a different needle but I don't change this syringe, you can have backflow into the syringe. So that was the risk that those patients, they were putting on those patients for not doing what they needed to do. So that's when the laser focus on infection prevention started. Not that it wasn't focused before that, but so many things changed in 2008 related to infection prevention. So let's look at what the moral of the story is. On the next slide, the moral of the story is that one bad apple equals stricter CMS requirements that started in 2008 and of course went into 2009. In 2008 and 2009, CMS brought forward a huge checklist of things that surveyors have to look for. And we'll talk about some of those as well. But it just takes one bad apple. So when we go in to do a survey, or when I am the interim director or director, administrator, and people say, well, this is just for business. There's no reason that we should have to do this. There is a reason that we have to be accredited. There is a reason that CMS looks at what we do. And this is a great example of why. It just takes one bad apple to make stricter requirements for everybody. So let's look at infection prevention and some of the things that the surveyor will focus on in the next slide. So if I'm the surveyor, and any surveyor will go in to do, the way that we'll go through this, everybody, is we'll look at the surveyor focus. What is the surveyor going to focus on most likely when they come in to look at infection prevention? Is this everything that a surveyor will look at? No. It's not. We cannot have anything that's all inclusive, but we can give you the highlights through this pocket guide that will help you understand and help you be prepared for the things that they're most likely to look at. It also gives you education and training, and it points you in the direction to get other information. So just like we were talking about in the things that happened in Southern Nevada at that surgery center, their injection practices were not what they should have been. So therefore, the surveyor is going to be highly focused on injection practices. Are you doing what you need to do? Are you using a different syringe? Are you using a different needle? How are you looking at your multi-use vials and your single-use vials? What are the things that you're doing for injection practices? Are those things being labeled? And all of this ties together. So we'll hit on some of that as well. Hand hygiene is a big deal. That's no surprise to anybody, whether you're in the field or not. We've had a huge focus with COVID on hand hygiene and washing your hands. It's no different when a surveyor comes in to look at your infection prevention practices. They're going to look to see, are you washing your hands? When you take off your gloves, are you using hand hygiene when you take off your gloves? Before you touch a patient, are you using hand hygiene? Those are all things they're going to look at. And by the way, the things that we're talking about here in infection prevention also go into quality studies that can be done, because people are always looking for ideas for quality studies. So these things that are on this list could also easily go into quality studies that will help you in addition to the things that you already are doing. Instrument endoscope reprocessing. There was also some problems in a surgery center, also in Nevada, where they were not processing their endoscopes correctly. There's not a patient on the face of the earth that wants to go in to a surgery center, to a hospital, and think for a minute that their scope, whether it's a colonoscope, whether it's a below procedure, or whether it's a procedure that's an upper procedure where they go down into your throat, there's not a patient on the face of the earth that wants to think that their scope was not processed properly. So that's one of the big things for infection prevention that is focused on. And also environment of care cleaning. There will be times when the surveyor will go through and look at the environment of care. How are you cleaning it? We've all become much more aware through this pandemic process of using wipes. And are they wipes that have Clorox in them? Do they, what is their dwell time? How long does it take to use them? Does your staff know how to do that? And then also they're going to be asking about the nationally recognized guidelines that you used. You can't just say, well, we use, we do injection practices because this is what we've been told to do. You have to cite AORN, you have to cite CDC, APIC, whatever you choose, but it has to be nationally recognized guidelines for infection prevention. And also not just for infection prevention, but also for your practice. And they will ask to see a list of those as they talk to you about infection prevention and how you take care of your patients. They'll also be looking at staff training. And when they ask about staff training, they'll ask your staff, how have you been trained in infection prevention? How do you know how to do this procedure? When we're talking about point of care testing, how were you trained to do that? So staff training and keeping track of that training and how you do it is going to be one of the things that they're going to highly focus on. So let's look on the next slide at medication management. And let's talk about that. We've touched on it a little bit in talking about syringes and what we need to do with those. Surveyor focus, again, laser focused on labeling of syringes and their containers. If I have that syringe that I was talking about, they're going to be looking here to make sure that whatever is in this syringe has been labeled properly. And you get what's required from those nationally recognized guidelines that we talked about. So you're going to need, among other things, the name, the dosage, when did you draw it up, how long is it good for, and who drew it up. Those are just some of the things, but certainly not an all-inclusive list. So they're going to be looking at that. On the back table of the sterile field, and when I talk about the back table, I'm talking about where the sterile supplies are, of course. On the sterile field, they're going to be looking at, you have liquid on your back table. What is that liquid? Because I can't just depend on somebody to remember that this is saline. It has to be labeled saline. If I have a medication on my back table, it has to be labeled. Anytime you have medications, they have to be labeled. And that's one of the things that they absolutely, and we as surveyors absolutely focus on. I will have some anesthesiologists that will say, you know, there's only one white drug, that's propofol. Actually, there is more than one white drug. There's only one white drug that they use for anesthesia induction, but CMS has not said, well, you don't have to label the drugs that are not, you only have to label the drugs rather that are not white. They have said you have to label all of your medications. And as having to label all of your medications, they do hold that to the standard. And when CMS comes in, when surveyors come in for a CMS survey, it is very black and white. You either do it or you don't, and you can correct it later. But when CMS comes in, you can't correct it right then. You can, but you're going to have to put in a plan of correction. And so if you do your homework on the front end and you do it correctly on the front end, then you don't have to worry about it. Again, that's being proactive. You don't have to worry about it on the back end. So medication reconciliation, this is one thing that I see quite a bit in surveying, and we've got to make sure, this is another one of their requirements, that your medication is reconciled. So if I take aspirin, let's say, over the counter, and that's anything that you don't get it from a pharmacist, that's not prescribed for you, of course, is an over-the-counter medication. And then the things that you get from your pharmacist or from your physician are prescribed medications. So when the staff is talking to the patients, they need to make sure that they get a full list of the patient's medications that they're taking at home, and then that those are recorded, that's over the counter and prescribed. And then also they have to have a list of those that were given while in your care. And the reason for that is so they're not given medications that they're allergic to, so that double medications are not given, and for among other reasons. And then also for patient education, when the patient is going home, if I, for instance, take blood pressure medication, then I need to know when I go home, when do I take my next dose of my blood pressure medication? That's very important if people are taking blood pressure medication, if they're taking diabetes medication, if they're taking medication for their heart, blood thinners. They need to know when to take those when they go home. So medication reconciliation is a big part of what surveyors will look at when they come in. Universal protocol, we'll talk about that next. Universal protocol, what is it? You will hear it also called timeout procedure. And some people will have questions about when is universal protocol required to be followed. The key is all invasive procedures that require an informed consent or that are done at the bedside. If it is an invasive procedure, you have to use universal protocol for it. The things that we typically see in surgery are going to be, of course, surgery procedures. It's going to be anything done in the surgical suite. We also see patients in the surgical suite, but also this outside the surgical suite that have nerve blocks. A lot of people are having nerve blocks today, much more so than in prior years. And they'll have nerve blocks before they go, before they go to surgery or after they get to surgery. You have to have a timeout for the nerve block. And you also have to have timeout for endoscopy procedures. If you're doing a gallbladder, a laparoscopic gallbladder on a patient, here are the goals down below. You'll see those. You want to make sure that you're doing the correct surgery. We're doing a laparoscopic gallbladder on the correct patient. And the correct patient may be Kathy Beydler. And then you also want to make sure that you're doing the correct site. So the correct surgery, the correct patient, the correct site. The correct site is going to talk a lot about laterality. If we're doing a carpal tunnel release, that would be your surgery. The correct patient would be Kathy Beydler, and the correct site would be right arm. So you can have the correct surgery, the correct patient, but if you don't have the correct site, you've just had a sentinel event. So you've got to have all of those on the patient. So, and you've got to have the checks for those. So that's why we do universal protocol. And the next slide talks a little bit more about universal protocol and what the surveyor will focus on. Let's go back to the carpal tunnel that we talked about. The correct site, the survey will be focusing on making sure that that site was marked before the procedure. And make sure that you look to see what your policy, that you know what your policy says. If your correct site policy says, your marking says that the physician has to put his or her initials at the site, then the surveyor is going to look to see that the site is marked with the physician's initials before they go back for the procedure. If it says that the correct site marking per your policy is yes, then they're going to be looking for the word yes at the correct site. Verification process with the patient involvement. If I am the nurse and the patient is Joe Smith, then I'm going to be asking Joe Smith, and typically my spiel will be, Mr. Smith, my name is Kathy. I'm going to be the nurse in the room with you today. Can you tell me who your doctor is? Because I'm verifying the doctor. Can you tell me what Dr. Whitman is going to be doing for you today? And I'm listening for what the patient is going to say. The patient has to tell me what the doctor is doing for them and then show me where the doctor has marked on them that correct site. Those are all things that I'm looking for before we go back, and then also that check before the procedure is started. During the timeout, this is huge, you guys. Please pay attention to the bolded word in this slide. It says all healthcare members stop and participate in the timeout process. If I am the surveyor, if anybody is the surveyor, and the circulator or the surgeon calls for the timeout, and everybody in that room does not stop, you absolutely will see that again as a deficiency. And that is something that will have to be corrected. And I always say to people, consider that when a timeout is called on the basketball field, for instance, or on the football field, people don't keep playing the game after a timeout is called. A timeout is called, everybody stops, the ref makes his call, and then you move forward. But you don't move forward until the timeout is over. So make sure that everybody in that room stops. I don't care if it's the anesthesia provider, the tech, the nurse, everybody stops when that timeout is called. That is something that you will be cited for if it's not done. And I see it more frequently than I can even believe, because they know I'm the surveyor and they know I'm there. So it amazes me that people don't stop. Willingness of staff to speak up. If something is not right during that timeout, I want to know that the staff are going to speak up during the timeout. Or if the physician has not stopped, or if anesthesia has not stopped, or the tech has not stopped, I want to know that that nurse or the tech or whomever in the room is willing to stop, to speak up, to make sure this process is done correctly. What hangs in the balance here? It's just not a whole lot, y'all. Jokingly, it's sadly to say, it's just the patient. And, you know, it's the patient and the patient's procedure and the patient's health. That's what hangs in the balance. And sometimes we get busy and we don't take it seriously enough. But it's not just a thing that we just check off for the day. It's not a checkbox that we do. It's something that actually helps us to take care of our patients and provide safe care for our patients. So let's look at quality improvement. We touched on that briefly. Surveyor, focus on that. Know which quality improvement process, on which ones your area is working. I will never forget, we had a surveyor at one of our surgery centers, and he asked one of the nurses, well, what QI projects are you working on? And she said, oh, we're not working on any. You guys, we had literally drilled this into their heads. We had worked on the projects together, and right before you go into the lounge, into the locker room area, there was a huge board that had a list of our QI projects and where the team was on each one. So we literally took her with the surveyor. It was too late because, you know, it was done, but we literally took her with the surveyor to that board and said, okay, let's refresh your memory. Here are the things that we're working on. She goes, oh yeah, I have heard about those. We have been working on them. Okay. So know which QI projects your area is working on. In the pocket guide, there will be blank lines for you to put what project your specific area is working on. There may be different projects for each area. It should be that way. You know, it should be different for endo. It should be different for the OR, SPD, whatever it is. If some of the ones are the same, that's good too. But you as leaders need to be prepared, and your team needs to be prepared to talk about how you're constantly improving processes for patient care. It's not business as usual, that you and your folks are constantly looking for ways that you can improve patient care and take care of your patients. That's what they're looking for in quality improvement. Point of care testing, we can talk about. Again, this came out as a big focus from CMS after all the hullabaloo in 2008 and 2009. And in your pocket guide, you have a place to record which point of care tests you are performing. Some of the point of care testing that you're performing may be glucose. You may be checking glucose for patients. You may be doing urine pregnancy testing. You may be doing INR, PT, PTT to see how thick or how thin a patient's blood is before they have a procedure. Those are all approved point of care testing. So know which ones are in your area, which ones you guys do, and then they're going to ask you, how are you competent to perform these tests? And the wrong answer is, oh, I knew how to do this from a previous job. Nah, that's not the right answer. The right answer is to give them the training that you had, and the training that you had where you are currently, and that you were checked off on these point of care tests. You want to make sure that your staff, that you're doing return demonstration with your staff. You can have super users that can train them, but it needs to be documented, and they need to know how they're competent. And when they get in front of a surveyor, sometimes people will be nervous, of course. Surveyors tend to have that effect on people. But if your people are prepared and you've done this work ahead of time, then they'll be able to roll off this information much more easily than if they're not prepared. Surveyors will want to know, how do you clean the testing devices between patients? Many of these testing devices involve blood. So the instructions for use, the manufacturer's instructions for use, or IFUs, will tell you how to clean the testing devices between patients. Make sure that your staff knows what those IFUs say and that they're doing what they should be doing based on that particular device. This seems redundant to have to say, but finger stick devices are for single patient use. That's redundant to say even to me in 2008, but clearly in 2008, that was not being done at some places. You guys have seen too, some of you that will see this have seen, and again, I'm going to use this as an example, and some of you who have diabetes will have seen something like this. It's a pin, and you take off the end, and you can put a lancet in the end of the pin. These are no-nos for multiple patient use. These lancets you cannot use for multiple patient use. So make sure that you're not using the lancet. If it comes with it, throw it away or give it to somebody to take home for use at their home for themselves. But you have to have finger stick devices that are for single patient use. Another thing that people are cited frequently on are that their controls and their test strips are out of date. When you open up control, particularly like, for instance, a glucose control, there is a date once you open it, and it depends on the manufacturer. Again, go back to those instructions for use. When you open those controls and those testing strips, it will tell you how long they're good for once you open it. If they're using it beyond that, if they've not labeled it, and or if they're using it beyond that use date, they will be cited. You will be cited for that. So there's some little tricks that we can talk about, if at a later date. I can't go into everything certainly in this presentation, but there are some tricks of the trade that can be used to train your staff to make sure that they label those controls, they label those testing strips for when they opened them, and then when's their last date that they're good for. One of the last things that we have to look for, and this is all based on CMS, you guys, this is not things that I made up or that any accreditation body made up, that you wear gloves when you're doing these point of care testing. You and your staff wear gloves. Anybody that does this, you have to wear gloves. And then once you take your gloves off, do you perform hand hygiene? Those are all things that are on the CMS checklist that you'll need to make sure that are done, and just to keep you out of trouble. And it's just good for patient care. All of these things just provide for good patient care. And talking about patient care, we'll go to patient safety next. And we'll look at things to talk about with patient safety. When we go into the hospital, and for those of you who had procedures that have given blood, that have just had your blood taken, they will ask you, Ms. Beydler, can you give me your name and your date of birth? That's typically the two patient identifiers that people use. And the staff will ask multiple times throughout a patient's stay. And patients don't understand why you're asking me, Joe's asking me, Josiah's asking me, Sarah's asking me. You've all asked me the same questions. It's for patient safety, to make sure that we've got the right patient for the right procedure, and that we are not making you vulnerable for an injury. You need to look at, where are your patients vulnerable for safety risks? What are the things as you go through your environment? And again, we become used to, if we're there all the time, we become used to just the way that we do things. As an interim director, I always go in, or as a consultant, I always go in, or as a surveyor, I go in with fresh eyes. I don't see your environment the way that you see it because I don't see it every day. So I'm always looking for where are you vulnerable for patient risks. I also serve as an expert witness. And as an expert witness, I will get calls saying that a patient has fallen out of a wheelchair. A patient has fallen on their way to the bathroom. They were not accompanied. And they're looking to sue. And they want to know if they have a case. So those are the things that you want to look for. Where are your vulnerabilities? The other thing is how do you and your staff report adverse events? If something happens, is your staff encouraged to bury it, to not talk about it? Or are they encouraged to report it and bring it forward to make it better? So we're looking for what's your culture in reporting an adverse event. If you're told, and staff many times will tell me, oh, we're told not to say anything about it, or we are told to report it, and we're told to report it in a incident report or whatever it may be. And every place has something different. But they want to know, are your staff encouraged to speak up? And then they will ask your staff, what is a sentinel event? What does that mean? And, sentinel event is something that has caused injury or death to a patient. Once a sentinel event occurs, which is considered a never event, once that occurs, what steps do you take? And then the next thing is, how do you prevent patient falls? Easy answers to that could be we put the side rails up. We make sure that the patient has their call light. When they go to the bathroom, we always make sure that they're accompanied by a nurse. We don't leave a sedated patient by themselves. There's all sorts of things that you do that you just need to take credit for in preventing patient falls. And then the last thing is, how do you prevent pressure ulcers? And I really believe we'll see a lot more focus on that in the upcoming year or two. The line is just being drawn. The connection is just being drawn in some areas more than others about patient pressure ulcers, and that many of them do begin in the operating room because the patient is lying in a particular position for an hour, 2 hours, 3 hours. So what are we doing to prevent pressure ulcers? And that all goes back to patient safety. It all goes back to risk management as well. When you see a patient that's had a pressure ulcer and has had to have a wound vac and has had to have some other things done, that literally has changed their life. And we need to be sure that we're not doing anything that negatively impacts patients. So let's continue with our patient safety and look at some other focuses that surveyors will look at. We talked a little bit about environment of care tour. Very common that surveyors will take environment of care tours with the staff and with the leaders. And if you as leaders think that your staff will not be involved, I will tell you, perhaps not 100% of the time, but a lot of the time, they're going to want to talk to your staff, not just to the leaders, because the staff is where you get the real answers and they get to tell you what they actually do. So the environment of care tour takes into account, what are you doing for fire safety? Where are your fire extinguishers, for instance? Are they in date? Where are your code carts? Are your code carts where they need to be? Is your equipment on your code carts what it should be? Do you have what you need in your code carts? And then we'll talk a little bit about the equipment on those as well. Shut-off valves, I see it all the time, you guys. We'll have shut-off valves for the oxygen and for the gases that typically are right outside the procedure rooms. And, there's not a lot of room in hospitals and in surgery centers. So we want to take tables or beds and put them right under. Here will be the shutoff valve. We'll want to put those tables and chairs right under the shutoff valve. The problem is this table is impeding your ability to get to the shutoff valve. So from a life safety perspective, you cannot have anything in front of the shutoff valves. I know that's inconvenient. And there's not a lot of places to put things, but it really is a patient safety issue when things are in front of the shutoff valves. They're going to ask about disaster preparedness. What have you done to prepare for a disaster? And your disaster is going to depend on, and your vulnerability for that is going to depend on what part of the country you're in. It's going to depend on if you have floods more easily. Many years ago here, and I'm from the Memphis, Tennessee area, we actually had Hurricane Elvis. That's no joke. Hurricane Elvis came through here and leveled a lot of things in the city and actually took the glass. We had one of our surgery centers had full front of glass, and it took all of the glass out of the surgery center, and there were patients and families in there that had to move to a safe area. So they're going to ask about disaster preparedness. If you're in a surgery center, they're going to ask you that even more heavily because CMS came out with some additional requirements for that in the last several years. Surveyors are going to ask about SDS. It used to be called MSDS, Material Safety Data Sheets. They're going to ask you where that information is located. Sometimes you'll have it in a big yellow and black book. Sometimes you'll have it on the intranet. You need to know, and your staff needs to know where that information is, not just where it is, but is the information that you need included in there, because everything that has that should have an MSDS sheet needs to be included in there, no matter where it's located. So equipment safety, let's talk about that next. It's a pretty purple banner. Surveyors are going to be looking at biomedical inspections of equipment. We're all familiar with it. If you work in a hospital or surgery center, it's going to be a little tag that says when the equipment was inspected and passed by Biomed. Many of them will have when the next inspection is due. So you need to make sure that all of your equipment has that information on it, that it's tagged, and that you go through and look at every piece of information, every piece of equipment to make sure it has one of those tags on it. I promise you, people will try to go through and make sure that everything is tagged and leave it to a surveyor to find the one or two pieces that are not tagged and that have to go out to Biomed. Again, if it's a CMS survey, it's black and white, and that will come up as a deficiency, and you will need to have that corrected and turn that in as your plan of correction. They're also going to be looking at staff inspections, how you document the equipment. Does the staff inspect the code carts every day? Do they look at the defibrillator? How often do they look at the defibrillator? Do they test the defibrillator? Do they test the suction cart? There'll be portable suction. Are you testing that to make sure it works? Because it doesn't help the patient and it doesn't help you in an emergency if you've just checked a box. And if the box said, yep, I checked it, but the defibrillator doesn't work when you need it. Not only is that not taking care of your patient, but it can do severe harm and create a sentinel event for your patient. And it can also land you in a deposition, which nobody wants to be in a deposition. Make sure that you understand the manufacturer's instructions for use. You will hear surveyors talk about that a lot. I talk about it all the time. How do you know how to use this piece of equipment? Doesn't matter where it is. How does the manufacturer's instructions for use say you should use it? How do they say you should clean it? Because it will tell you all of that information in the IFUs. And you should have a book or some resource, whether it's, I think it is called onesourcedocs.com. I don't have any stock in that company. But when people say they have onesourcedocs.com, then that gives me some sort of peace and assurance that they've actually looked at the manufacturer's instructions for use and understand the process. If you have a piece of malfunctioning equipment, what do you do with it? Do you just put it out in the hallway and say, yeah, that didn't work? Do you label it? Do you give it to Biomed? Do you notify somebody? Because you don't want that malfunctioning piece of equipment being used on another patient. And then another thing that surveyors will look at is recalls, whether it's a recall of a piece of equipment. And if a piece of equipment has malfunctioned, you guys, or if it's been recalled, do not give it to the sales rep until that has been cleared by your director or administration. Because sometimes, unfortunately, sales reps will take it and you have to do the follow-up on that. So do not release that piece of equipment or that recalled information until you've been told to do so. Make sure you follow your policy and follow safe practices on that. All right, the next thing that we're going to talk about is patient rights, and they're pretty green. Excuse me. Patient rights, big deal with surveyors, big deal with CMS and all accreditation bodies. I've gotten calls for expert witness about documentation of pain. Did the nurse assess the pain? Did she treat the pain, or did he treat the pain? Did you document it? Remember, we learned in school, if you didn't document it, what is it? If you didn't document it, you didn't do it. So you've got to have the assessment, the treatment, and the documentation of the pain. Make sure that you're going, of course, within the protocols set up, that they're acceptable protocols, that your anesthesia is involved in it, and that you're giving the correct pain dosage when you're supposed to give it, and that you're documenting it. Part of that assessment is going to be either, many places use a pain scale, either 0 through 10 or 1 through 10. For kids, they may also use the FACES pain scale, where they'll show the children the face and show them which face they think they are, or they'll look at the patient and make that decision. But all that has to be documented. Patient rights, make sure that your informed consent is documented. Do not do anything on a patient unless it's an absolute emergency where you have not, the doctor has not obtained an informed consent. And we could talk about that at length, but again, we don't have a lot of time to go into detail today, but that's certainly something we could talk about at length at another point. Patient complaints and grievances, you have to keep track of the patient complaints and grievances and how you dealt with them. You also have to have a policy that says, how long do you have to respond to a patient after they have filed a grievance with you? And you need to have the documentation that supports that. Advanced directives, big deal, particularly today. The purpose of advanced directive in a surgery center is so that you can understand how patients want to be treated in a hospital setting should you have to transport them to the hospital. The advanced directives for a hospital is, do I want, do not resuscitate? What do I want to happen in an advanced directive? So you always ask a patient if they have an advanced directive, and if they have it, where is it located? And record, excuse me, record where it's located. If they have an advanced directive that they brought with them, get a copy of it and put it in the chart. And then also know for patient rights, what type of interpreter services do you have? Do you have some people call it the blue phone. Do you have the blue phone that you take into a patient room? Do you have an iPad? Do you have an actual physical interpreter? And then what do you do for hard of hearing and for deaf patients as well? So know what type of interpreter services you have for that include patient rights. All right, I'm going to take a drink, and we're going to talk about communication so that I can continue communicating here with you. Surveyor focus on communication. I cannot stress communication enough, guys, both with your staff and between leadership. Surveyor focus is going to be on patient and family teaching. We touched on that a little bit when we talked about medication reconciliation. You can talk to the patient about when they need to take their next medication dose, but they've been under anesthesia. So you also need to make sure that their family member, the person that's going to be staying with them for the next 24 hours, understands that as well, and that you document that in the medical record. Handoff communication, we've heard this over and over throughout the years. I can't tell you from a risk perspective how important that is for you to document that, document the handoff communication, not just between the nurses, but between other healthcare providers. Document the communication that you get from physicians, the orders that you get from physicians, the orders that are relayed to you from other nurses that a physician may have written, and they just want you to be aware. Test results are big in communication. You want to make sure that you get those test results to the right person on time. If a person's INR is too low, if their bleeding time, for those of you who may be lay people, if their bleeding time is taking too long, if it's taking too long for them to clot, you need to know that, and the doctor needs to know that, and anesthesia needs to know that before they go back for their procedure. So make sure that those test results that were ordered are on the chart, and that the person who needs to know that information is given that information before it started. Critical results are reported and documented. One of the critical results that stands out to me during this time is, what is your COVID test result? Is it negative or is it positive? And that result can make a big difference in what happens with you and what precautions the staff and the physicians take for procedures that are not elective, for sure. All right, so let's talk about tips related. We talked about communication. Let's talk about tips for talking to a surveyor. And these are things that you probably won't know unless a surveyor tells you. One of the biggest things that means a lot to me as a surveyor is when I am welcomed into a facility, whether it's a hospital or whether it's a surgery center. Make sure that your people know to smile. Are they going to be scared? Probably so. They're afraid they're going to say the wrong thing. They're afraid the surveyor is out to get them. I can promise you this, there is not a survey, and I've done over 200 surveys to this point. There is not a survey that I have gone into where I said, boy, I cannot wait to see what I can find on this organization. I cannot wait. People just don't do that, y'all. I know that that's sometimes the reputation or sometimes the way that it feels, because we come in and we look with different eyes and we see things that you don't see. The one thing that I remember very distinctly is I had a technician, a surgical technician. I was headed back to the operating room, and she met me in the hallway, and she said, Miss Beydler, my name is Cynthia, and I'm going to be the technician in the room with Dr. So-and-so today. And I'm so glad that you're here. I want to take you into the room. I want to show you what we're doing. I'm telling you, folks, you do that, and that will absolutely give your surveyor confidence in what you're doing. She was not afraid. She was taught to come and welcome me. And as you can see, in over 200 surveys, that's one of the ones that sticks out. Can I tell you the name of the facility? I cannot, but I can see exactly where I was in that hallway. I can see her, and I know what she said to me. And those are the things that will make a difference in your survey. Answer questions, but don't elaborate. Remember, for those of you who are of my generation, you don't have to raise your hand. I'm good with that because I'm maybe the only one in this generation. But remember, they used to say, just the facts, ma'am, just the facts. That's what you want to give them. If they ask you a question and you don't know the answer, it's okay. You don't have to know every answer, but you need to let them know that you know the resources. If they ask me what a policy is for environment cleaning, and I just go blank for a minute, I can say, you know, I know where to get my policy for that. I have my resources. My manager, Joe Smith, can help me with that. And I always have resources available to me. And if you say those things, they're going to leave you alone. Welcome them, smile. If you don't know the answer, identify your resources. The last thing, one of the last things on here is always tell the truth. Never, ever, hear me, people, never lie to a surveyor. I don't know what it is, but surveyors have innate lie detectors. Some people call it other things, but for the purposes of here, I will call it a lie detector. We will know when you are lying to us. Do not do it. When you lie to us, we will know it. And then when you lie to us, we have to dig deeper. It takes more time. It becomes painful for you. It becomes painful for us. And nobody wants to go there. When we start digging, then we generally find things that nobody wanted us to see. We didn't want to know, but we have to because we can't trust you. So you want your surveyor to be able to trust you. You want to tell them the truth and move forward from that. And then the last thing is be proud of the care that you provide. Nobody goes into this calling, if you will. Nobody goes into this business trying to hurt patients unless you're a sociopath. And hopefully we can root out the sociopaths before they get to patients. But everybody wants to provide good care for patients. You know, we don't want to go home and have that on our conscience that we did harm to a patient today. So be proud of the work and the care that you provide, and know that if you're proud of it and you're doing a good job and your heart is in the right place and you want to learn, let the surveyor know you want to learn. If there is a better way to do it, please let us know. I've seen over 200 places, and I might have ideas that you haven't seen before. And I guarantee you, when I come into your facility, I will see things there that I have never seen before. Good and bad, but generally good. And that always, I just put that into my file of things that I can share with somebody else. So be proud of the work that you provide and know that you're going to do great on your survey. If you're prepared, if you're proactive, you're going to do great, hands down. All right, let's get to questions. What questions do you folks have of me?
Okay, Kathy, that's a wonderful presentation. Thank you very much. I had told the team that this was going to be full of the content that we eat, live, and breathe every day, all day, and in fact it was. So thank you so much. I've got 3 questions. One comes from Eric. Eric asks, what is the motivation by which that 2008 event occurred? Why were they sharing syringes? What is the behavioral, what is the cost cutting or the corner cutting that is achieved by reusing syringes? And that brings up a more general question, which is, what are the behavioral motivations that you see that cause people to get findings when the surveyors come?
Several things. In the instance of the sharing of syringes in Southern Nevada, I actually went back and did quite a bit of research into that one, and I found out that it was a physician-owned surgery center. I'm not at all casting a pall on all physician-owned surgery centers, but it doesn't even have to be physician-owned. But sometimes when it is, or when pressure is put on staff to save money, then that's when that happens. Syringes are so cheap, you guys. And so when you get to the point of you're asking people to share syringes to save 3 cents or whatever it is, that is severe. And there had actually been several people that had come forward to the leadership of that surgery center and had voiced their concern, but it had fallen, unfortunately, on deaf ears. So the other part of the behavior, and I'm sorry, I got to the cost cutting. What is the behavior? What was the other part? Oh, the other part was, why do people do the things that they do? The behavior part of it, right, Josiah?
Right.
The behavior part is, some of it is ignorance. I went into a surgery center, a very good surgery center, and they were using a vented needle, if you will, so they could draw up multiple doses of, say, Marcaine, if you will. You cannot use a vented needle in drawing up multiple doses. So I picked that up, and it's just something, again, they're used to seeing it and they're used to doing it. So part of it is they just don't know, and they've never had anybody tell them. So I actually went back, and because they had so many questions, and if you have questions during a survey, please ask the questions. I would never argue with the surveyor, because you will have your opportunity to give your side of the story and provide additional information after the survey, but you don't want to argue with the surveyor. She did have some legitimate questions, which I was able to go back and research and give her the reason of why you don't use anything vented. And they were using that for multiple patients. And I said, absolutely not. You need to take this. You need to get rid of it. And they did. So some of it is just ignorance. They just don't know. And it's hard to keep up with all of the things that are required when you're trying to run a surgery center, trying to run a hospital, because again, the information doesn't get sometimes to where it's needed.
Right. Okay. Next question. By what percentage of surveys come back with 0 findings?
Very few.
Yeah. What come back with need for additional return visits? What percentage come back with reduction in CMS reimbursement? And what percentage come back with the OR being shut down for a period of time? Do you know the data?
I don't know the exact percentages, not to interrupt you, I'm sorry. Was there another?
No, that's it. Yeah.
Okay. So the percentage of surveys that have no findings, I've actually had a few. Out of 200, I've had a few. It is rare. It may be something just as simple that a finding just as simple as point of care testing, or maybe as simple as how they're not labeling their medications. It could be as simple as not labeling high alert medications. And again, there are so many things that we could go into, but most of them come back with at least one. Many of them come back with several. Anything that's considered immediate jeopardy, which would provide harm to a patient, the survey is stopped immediately. And the home office of whatever accrediting body you're using, whether it's AAAHC, DNV, or the Joint Commission, those are called immediately, and then they notify CMS if it's a CMS survey. So if you walk in and there's something that you see immediately that is going to cause harm to a patient, that's called immediate jeopardy, the survey is stopped at that point, and then the home office is called, and then they will determine what happens after that. For an immediate, can they get through an immediate jeopardy? Yes, but it's got to be corrected, and that's going to, in the most times, require at least one, if not more, return visits, which ends up costing the facility a lot more money. Again, if they had been proactive and getting it done, it would have saved them a lot more money on the back end rather than being reactive and waiting for somebody to find out, and to see what they were actually doing that was wrong, that was a discrepancy. And then as far as the return visits, I've had, I don't have a percentage of that, but in 200 surveys or over 200 surveys, I've probably had 10 or 15 that have required return visits. If it's CMS, it's going to require, and particularly if it's CMS, and it's something serious, it's going to require a return visit. Sometimes the same surveyor does a return visit. They actually like that because we're familiar with the facility, but sometimes it'll be a different surveyor. For a return visit for CMS, you will never know when they're coming. They can show up any day, and it is not broadcast to the surgery center or the hospital for that matter. But CMS, you don't know when they're coming at all.
Tell me a little bit about COVID. Now, 2008, we had this event that has changed sort of the world structurally when it comes to surveys. You've got to think that COVID has caused some structural changes as well. What can you predict will be COVID-related structural changes for 2021, 22, 23 in the future?
Some of them we've already begun to see. When I was the interim director recently in Oregon, we had a DNV survey that was a virtual survey. And I don't know if you guys are familiar with Big Bang Theory, but there was Sheldon had an iPad on a pole, and he was, or a computer on a pole, and so he would ferry himself around, and he had, I think he had a T-shirt on. So we literally had something like that related to DNV because it was in, trying to think, it was in 2020, but because of COVID, they were doing not on-site surveys, they were doing virtual surveys. So they would tell you what they wanted to see, and then you would take the IV pole where the iPad was mounted, and it had the surveyor's name on the IV pole. And so you would take the IV pole and show them what they wanted to see. So it's totally different than what we're accustomed to. But some of that I think we'll see more of. Some of the, I've done actually some on-site surveys during COVID, and you just have to be aware of, wearing a mask and making sure that you're fully protected, but we see both.
Fascinating. That's interesting. I like that idea. And I think we've all seen those iPads connected to poles, and who knew that Steve Jobs would have that vertical, right?
Right. Yeah.
So if I'm a chief operating officer and I want to reach Kathy Beydler, how do I reach Kathy Beydler?
Kathy Beydler, if you're a chief operating officer and it's related to the pocket survey guide called Whitman Partners, called Josiah Whitman. I also have email at Whitman Partners. It's kathy.beydler@whitmanpartners.com. So anything related to coming on site or related to that would go through Whitman Partners.
Oh, that's very generous of you. Thank you, Kathy. Kathy, thank you so much for your time today. So helpful for our team, helpful for the community, and we really appreciate your time and, frankly, your time building this. What a great work that you've done, and we look forward to seeing if we can spread the word.
Thank you, and I appreciate your partnering with me and seeing the vision in it. It's been a work of, frankly, of love and of passion, because I just want patients to be taken care of, and I want people to fully understand what surveyors will be looking for and how they take care of their patients. So it has been an absolute pleasure, and I look forward to continuing the work.
Okay, thank you so much, Kathy.
A pleasure. Thanks, everybody.
Bye-bye.
Bye.